This is Pretty in Practice, the podcast.
Opinions expressed on this podcast are solely those of our own as well as our guests and do not reflect the views and opinions of our respective employers, organizations, academic institutions, committees, other groups, or individuals.
All right, welcome back to another episode of Pretty in Practice, the podcast. So today's a very, very special episode. It's our first episode where we get to have a guest. We have our usual host, Justice, D'Angela, and India today. And our special guest is a good soror of ours and a Fort Wayne native like myself. She is an OBGYN. So we'll have Dr. Elicia give a little bit more about herself.
Hello, everyone. Thank you so much, sorors, for allowing me to participate. It's definitely an honor and a privilege. I would say, to introduce myself, as Justice mentioned, I am originally from Fort Wayne, born and raised, graduate of Concordia Lutheran High School. I then went to Purdue University for my undergraduate studies, and then went on to medical school at Indiana University School of Medicine, where I had a unique opportunity to have a full-ride scholarship, academic scholarship to medical school. So I'm happy to discuss more about that and how I got that, because I know that is something that's very unique. Then after medical school, I entered my residency program at Indiana University School of Medicine, again in Indianapolis. And my residency program is in the specialty of obstetrics and gynecology. I completed residency in 2013 and moved back to Fort Wayne to start practice. And I began practicing in a private practice called Women's Health Advantage in Fort Wayne. And when I came back to Fort Wayne, at the time, my father was ill, and he's since passed from cancer. But I came back for two reasons. One, I wanted to be close to my dad as he was going through his treatments. And secondly, when I came back, I was the only Black OBGYN in the city. And I also speak Spanish, so I took care of the entire minority population of Fort Wayne. And I got very busy very quickly. And so that was a unique opportunity to kind of build a practice and start in private practice, and to be the first in my practice history, and then became the first partner. And then I started to heavily recruit other women that look like me for several reasons. And I can, elaborate on those reasons as we talk some more. Then I decided, after my dad passed away, life is short, and I was working entirely too much, and I was prioritizing patient care over my own self, and was, my life consisted 90% of work and 10% of fun. So I looked at what opportunities I had to really focus on things that were important to me, which is high risk obstetrics, and how could I work smarter and not harder, more efficiently. And so I changed career paths and began to practice as an OBGYN hospitalist in Indianapolis, Indiana. So I currently work at Community North, which is the highest acuity, highest volume hospital in the state of Indiana. And I take care of the obstetrical patients that are transferred in from all over the state that have the most severe cases of different pregnancy complications. And I manage them, and I also take care of the normal labor and delivery with assisting the generalists with the care of their patients. And what's fantastic about the lifestyle is that I work 8 25-hour shifts a month. And so it's like, when I'm there, like all pedal, all gas, no brakes, right? And then when I'm off, and my life is my life, and it's my time. And so I've definitely find that has been a great work-life balance for me, which I think is one of the unique things about my job, And it's kind of a new trend in the area of medicine, as we find that doctors have the worst work-life balance when you look at professions in general. And there's a very high burnout rate right now. A lot of people are leaving medicine because of the imbalance that they have. And so I think that that's something else we can kind of talk about, if not today, in the future, kind of my change and my career path. And with having all this additional time, I thought, well, you know, we're in a pandemic, right? Everybody was at home. They was learning to make bread, crafts, like, and I had all this extra time, and I was in the house, and I was like, what can I do? What can I learn? How can I utilize this time? And I decided to get a physician executive MBA. And I felt like that was the definite knowledge gap I had coming from medical school, not knowing anything about business. And you will soon experience this, going out into private practice where you have to do billing and you have to manage a practice and you have to do profit sharing. And you realize as a partner that you don't make any money if you're doing all the work until all the bills are paid. And so I felt taken advantage of in a lot of situations from my previous employer. And so I was like, I just want to learn more about the business of medicine. So I finished my physician executive MBA in May and taking on some new opportunities, thank you, in the realms of physician leadership, with community network, getting more involved in diversity, equity, and inclusion, and recruitment of other minority providers for our network. And also, I am a part of a startup that focuses on decreasing maternal mortality. And we'll talk more about that horrible situation. But it's a medical technology startup consisting of Black women that work in healthcare, business, pharma, corporate America. And so we have developed a technology that is utilized to supplement the traditional approach to prenatal and postpartum care to hopefully replace the implicit bias that decreases our outcomes with objective information. So yeah, we can talk more about that. But yeah, I've gone from Fort Wayne, Purdue, IU, back to Fort Wayne, back to Indianapolis, and now entering more of the business realm of medicine. And so I've learned a lot along the way.
I will just jump in and say that's a epitome of excellence. Sorry, Justice. I just wanted to comment. That is just excellent.
Necessary.
Yeah, real life goals.
Yes. Well, thank you so much for sharing that with us. Yeah, goals. So yeah, we'd love to jump into some more Q&A with you, find out a little bit more. But as always, we have to jump into what's called our Doctor's Diary segment. And since you're our guest, we'll definitely have you answer first. But our question is, what are you proud of? What are you most proud of in the last year?
Oh, okay. So as I mentioned, I finished my physician executive MBA. And so I'm very proud of myself in that, you know, I hadn't been a student in a long time. So to go back to like having to take tests and study when you haven't done that in like more than 10 years, I was like, this is real. And like, they're like, okay, we need you to read this book by next week. I'm like, which chapters? They're like, the entire textbook. Like, oh, okay. So, you know, working full time. I did not decrease my hours. As an OBGYN, where we were in a baby boom. So work was popping. It was busy during a pandemic. And I graduated with a 3.9 cum GPA.
Yes.
So I'm proud of myself for that.
As you should be.
That's awesome.
Yes. And we are proud of you.
Thank you.
Very much so. I'll go next. I say that I'm probably most proud of. I had a speaking engagement with like middle school and high school students, and my topic was like making lemonade out of lemons, basically. And I was able to kind of break it down into like a kid type formula, and kind of give them some insight on what it's like to continue on, even though like Life hands you lemons. So yeah.
We are proud of you, Justice, for pushing through with that.
Yeah, definitely. I don't know how you did it, but it's amazing.
Me, God.
I'll go ahead and jump in, and I don't even know if you know this yet, Dr. Harris, but I'm proud that I actually ended up getting out of Indiana. I've been born and raised in Indianapolis my whole life.
I know that you
I know, that's why my life has been so crazy. These last couple of weeks, I literally just moved to Fort Lauderdale, Florida last Thursday. So yes, my husband got a promotion. Huge congrats to him. But it's my first time getting out of Indianapolis and exploring life and living my own path. So I'm excited about that.
That's amazing. I might have to come and visit you.
Yeah.
One of my
Please
good
do.
friends is trying to recruit me to take a job in Fort Lauderdale.
Oh yes, I'm gonna be recruiting as well. So yes.
Come on.
Please.
So I guess I'm last. I am most proud of finishing my first year of accelerated medical school. It was a whirlwind and I had my highs and lows, but I'm like super excited that I'm finally a second year. So yeah, I would say that's my biggest accomplishment or the thing I'm most proud of in this past year.
And that is something that is exceptional because a lot of people
Thank you.
So proud. Okay, awesome. I love all of this Black girl magic. But now we'll switch over to giving people more content and just allowing them to dig into some of the topics that you previously talked about, Dr. Harris. But first, just circling back around to something that you said at the beginning of the show, your selection of OBGYN as a career path. Can you talk a little bit more about that selection? What prompted you to go that path?
Yes. So when I was in medical school, and Dee probably will experience this, they teach you so much medicine. They just throw medicine down your throat, like internal medicine, just learning it all. And so I didn't really know what I wanted to do, but I entered medical school with very little knowledge of the realm of OBGYN. So much so that when people were asking me as a first year, what do you think you want to do? I said, I have no idea, but I know I'll never want to be an OBGYN or a psychiatrist. And like, here I am, right? And I think what is so funny about that is because my understanding of OBGYN came from high school. I went to a private Lutheran school. We had a class that was called Love, Marriage, and Family. And the entire purpose of the class was to deter you from premarital sex. So they had us watch traumatic birth videos. That was like cameras here, baby rips mom to 4th degree laceration. And I can remember being so horrified from watching that. That was my entire, knowledge base of what it was like to give birth, because I'd never, been in a room with anyone who had given birth and had, no experience with that. But as I became a third year and you do your specialty rotations, like the clinical clerkships, I had my surgery block last. And so going into my surgery block as a third year, you're preparing yourself mentally to apply for residency. So you have to select an advisor. And so I was like, well, I've done medicine. I like that. I've done peds. I like that. So maybe I'll do med peds. And then when I got to surgery, I was like, ooh, I like surgery. I was like, this is interesting. I like the immediate gratification of the patient has a problem, you fix it, they go home, they're great. That's what I really liked. I felt like I could really impact people's lives in a short period of time. And so I started off from surgery, and my very last rotation of third year was OBGYN. And that put the medicine, the pediatrics, and the surgery together perfectly for me. Another thing about me just as a person is I am very much a feminist, like to my core, like about women's rights, equality, reproductive justice. And so it fit my personality very much, because I'm also like a dominant alpha type of female where I like being in charge. And so there at the time when I was considering just doing general surgery, there weren't any Black women in general surgery at the institution I was in, so I didn't really have a strong mentor. But there were lots of women and a few Black women where I was that, you know, kind of were like, you have a natural talent for this. And when I did my OB rotation, I think they recognized my passion that I had and were kind of pulled me to the side and was like, you really need to consider OB, which further made me think, okay, trauma surgery or OBGYN. Because I had people that were kind of recognizing my passion and feeding into me in the realm of OBGYN, I chose that over surgery.
Amazing.
And I feel like it's a perfect fit for me.
It's so funny when you tell God your plans and he kind of laugh at it.
Right. But that's amazing. Yeah, that's amazing. My best friend, she just started her first year residency in OB at Duke, and I'm just so proud of her. But similar to you, she loves surgery and she's a super feminist, so it makes sense. So while we're talking about OB, I'm going to ask Dr. Harris a few questions. We're going to dive into some of the more common conditions that you'll see, and especially those that are affecting women of color. So I'm going to start with fibroids, also known as like fibroid tumors. So according to the Cleveland Clinic, approximately 40 to 80% of women have fibroids. In addition to the prominence of fibroids, African American women are more likely to develop fibroids than white women. So, Dr. Harris, I wanted to ask if you can tell us a little bit more about fibroids, so like what it is and how they present clinically.
Yes, definitely. So, as you mentioned, fibroid tumors are more prevalent in the African American community. And what they are is they are benign tumors that form in the uterus. They can be in the cavity of the uterus, in the muscular wall of the uterus, and then on the outside periphery, which we call the serosa of the uterus. And so their location can affect the symptoms that someone would have and vary the severity of those symptoms. So most fibroids, as I mentioned, are not cancerous, and they usually start to develop around women's reproductive ages. And as we age as women, the prevalence of fibroids increases. So, you know, you mentioned that the prevalence, there's a huge range of prevalence, right? And so it's based off of your ethnicity and your age is what, you know, the likelihood that you would experience them. And I would say the most common presenting complaint is change in menstruation, where you have heavier periods, you have longer periods, you can experience periods that have more clots, large clots that a woman is passing, which then subsequently causes more pain during their period. Another thing is you can have like a pressure type of symptom where you feel pressure with exercise, with intercourse, just with your daily activities. And if they're large enough, you can like visibly see that your abdomen looks distended. Or, you know, you're working really hard and you're in the gym and it's like, my belt, this pooch is not going anywhere. So I would say that the most common complaint is the change in menstruation. That's the first symptom that women will have. And those symptoms and the severity will depend upon the location, with the fibroids being in the cavity, which can sometimes be what we call submucosal, where they're actually in the lining. That has the most impact on blood loss that someone experiences during their periods.
Okay.
So
go ahead.
I was just going to say, sometimes women can lose so much blood during periods, they become severely anemic. They come in passing out, feeling very fatigued all the time, have to get a blood transfusion in the ER, all from being chronically anemic from the heaviness that their periods bring as a result of fibroids.
And can I ask a follow-up question to this? Because here we like to keep it real and honest. And recently I found out that as according to the stats, I'm a woman who actually has fibroids. So that is currently impacting me. And I know one of the biggest questions that was on my mind is about, does that impact my ability? Like, what is that going to look like? Because you talked about us being of childbearing age, usually when it arises. How does that impact the ability to actually birth children?
So it depends on how big the fibroid is and where it's located. So if it's subserosal, which is on the outside, kind of like a Mickey Mouse ear or piggyback ride on your the fibroid is hanging on to the uterus, it has very little impact on your ability to have a baby. But if it's in the cavity and it's occupying space in the cavity where the egg and the fertilized egg needs to implant, that can impact your fertility and your chances of getting pregnant. And sometimes that can impact your ability, once pregnant, to have a full-term pregnancy. Because if that is occupying so much space in your cavity, your uterus can only grow so much before it's impacting the growth of the baby, and your uterus thinks it's more pregnant than what it is because it's so overdistended. It'll have more contractions, premature contractions, which can result in a preterm birth. Mm-hmm. So it's a complicated situation, but I'll tell you that a lot of fibroids can be removed if they are the size where they can impact fertility. And the submucosal fibroids, the ones that are in the cavity that are the most troublesome, that cause the most symptoms, that impact fertility the most, are the easiest to remove because you can go in the cavity and literally shave it out. So you can go through the vagina, which is called a hysteroscopic myomectomy, versus having to have a big abdominal incision to remove it if it's in the muscular part of the uterus or on the outside of the uterus. So I myself had submucosal fibroid that was 6 centimeters. It was huge. I mean, it was to the point where it's like I'm operating on women, doing robotic hysterectomies, looking at their massive fibroids, taking out their uterus, and can feel myself like bleeding out. But I can't get up and walk away from the robot as I'm operating. So I would have to double up and just take preventative measures. And I'm like, this is ridiculous. Yeah. And so I'm like, I'm going to go get my own surgery because here I am operating on women for this condition and my symptoms are probably worse than theirs. So I had a hysteroscopic myomectomy, which was done by my friend and colleague at the time, Dr. Emery Butler, who's another Black OBGYN. She's a Delta, but we won't hold it against her. We love her. And so, I had that as an outpatient procedure, took one Tylenol after that and was good and haven't had an issue since. So I say that to say, I think there's just a lot of myth and, things that Black women are often counseled that they have to have a hysterectomy if they have fibroids. And if they don't have a hysterectomy, they won't be able to, there's no solution. It's basically you bleed until you get a hysterectomy. Right. Or if you have a myomectomy, then you have to have a big incision. And there's lots of options that you have before you get to that point.
That's comforting. So anyone listening out there dealing with it, know that there are options. So thank you for that.
Okay. And so you kind of mentioned how it's treated in a sense. So we know it can be surgically removed. Are there any other treatment options? And also, is there any way to prevent fibroids?
So unfortunately, there's no way to prevent fibroids.
Okay.
And that's because we don't truly understand the etiology of where they come from and why as Black women we're more affected. There has been some theories that it's like our hair products, like we used to, everyone used to relax their hair commonly, but even though with this whole movement to wear our hair more naturally, I feel like the minority of women are relaxing their hair. And at the same time, the prevalence of fibroids hasn't changed. So I feel like it's probably multifactorial why we're more affected. And it's not solely just our hair products. So unfortunately, there's not really anything you can do to prevent it. I think it's beneficial to be knowledgeable about your family history. So if your mother was affected and your sister was affected, that you can mention that to your OBGYN because it's diagnosed very easily just by having an ultrasound. So if you have several women that are affected, you notice a change in your periods, I would be communicating that to your provider so they can do an ultrasound to diagnose you before they become, they increase in size based off of hormones. So the longer they're present over the time that you're menstruating, the larger they will progressively become. They also grow significantly as a result of the hormones of pregnancy. So a lot of women, they'll go into pregnancy with a small fibroid, and then at the end of the pregnancy, that fibroid is 2 to 3 times its original size prior to pregnancy, which then can impact their life after and subsequent pregnancies. So I think it's just good to be knowledgeable about, do you have fibroids, so that you can take a proactive approach and make knowledgeable decisions about your fertility.
Okay.
There was something else that I was thinking of. Can you repeat? I know there was
the other thing was, like, other than surgery, are there any other options for treatment for fibroids?
Awesome. Yes. So firstly, there's medical management. And as I mentioned, because it's affected by your hormone cycling, if you choose to get on a hormone suppressing birth control, that can prevent the overall growth over time of the fibroid. So like myself, I take a birth control pill every single day, and my fibroid has not recurred since I had it. And so that is one option. That's also an option of management, so that if you are experiencing very heavy periods, when you take birth control pills, it tends to decrease the amount of blood loss that someone experiences during their period. So medical management is first. And then you have surgical management, where you can have a myomectomy, which removes the fibroid. There is also this new technology that's come out in the last 5 years that uses radio frequency ablation. So it can be done laparoscopically, where this instrument is inserted into the fibroid, and it uses this radio frequency to kind of ablate the fibroid and decrease the blood supply, so the fibroid then dies without having to be removed. Just by cutting off the blood supply, it will decrease in size over time. There is also something called a uterine artery embolization, where it's done with interventional radiology, where they cut off the blood supply to the uterus, and in turn can cut off the blood supply to the large vessels that are feeding this fibroid. So it's not cutting off the blood supply entirely, where, the uterus doesn't die in itself, but
I was like,
things that are depending on, like the fibroid, it'll slowly, kind of, this blood supply is compromised. So if it does continue to grow, it won't grow at the rate that it has. But I will say, if you're considering having a baby after that, that's not a choice that I would make, because there's not any great studies on how that can impact pregnancy in the future with having decreased blood supply to the uterus. And then lastly is hysterectomy, to remove the uterus in its entirety. And with removing that, you remove the fibroids. Because I think one thing that I didn't necessarily mention is that if you have a myomectomy, you remove a fibroid, it can come back. Or, we're not going to go after and make incisions for the tiny, tiny little ones. And the tiny, tiny little ones can continue to grow after you've removed the larger ones. So that is just something to consider when someone has a myomectomy, that just because you have that one surgery, that's not the end all be all, that you may not have to deal with the situation in the future.
Oh, that's really good to know.
Yeah, so listeners, make sure you get all of the options. If you are facing this issue of having fibroids or recurring fibroids, please make sure you ask all the questions, because as you can see, she mentioned hysterectomy as like the last choice. So don't let nobody tell you that it's like the first choice. There are options. So thank you for that, Dr. Harris. We'll move on to our next GYN condition, which is endometriosis. So according to Johns Hopkins Medicine, endometriosis is a common gynecological condition affecting an estimated 2 to 10% of American women of childbearing age. So could you talk a little bit about endometriosis, so what it is and how that presents clinically?
Yes, so endometriosis is where the lining of the uterus that is shed when you have a period has somehow migrated beyond where it's supposed to be. Okay. So if you could imagine, if you had lining of your uterus growing inside your peritoneum, which is the lining of your abdominal cavity and your pelvic cavity, then when you hormonally cycle, you are having internal bleeding in your abdomen. And blood in your abdomen is an irritant, and it's very painful. And so that's why when people have any type of a ruptured organ or a stab or a gunshot wound or any type of trauma, typically the pain results from the blood being in their abdomen, right? So endometriosis is that lining cycling, shedding, bleeding when you're hormonally cycling, but it's in places that we can't necessarily get to. You can't really see that. That blood isn't coming out of your body. So the main presentation is painful periods. Not a change in the flow, just pain that is out of proportion from what they previously experienced or what is typically just taken care of by an ibuprofen.
Yeah, I have a friend who has endometriosis. It's been a long road, long journey with her, but I remember when before she went in and got diagnosed, she was having horrible periods to the point where she couldn't come to class. And I remember talking to her about it, like, I don't think that's normal. Like, she was asking me, like, have you ever had a period like this bad? And I'm like, I'm not having. You should probably go get that checked out. And it did turn out to be endometriosis. So thank you for giving us, that definition, just in case anyone is experiencing like these extremely painful periods. That's something to look into. And then similar to the last questions, is there any way to prevent endometriosis? And also, how is endometriosis managed clinically?
So unfortunately, you also cannot prevent endometriosis, but also similar to fibroids, if you have a strong family history for it, you may be more likely to experience it. So if your mother had, periods that prevented her from going to school every, menses or going to work, or your older sister experiences it, you might know that you might be at a higher risk for experiencing that yourself. So again, it's just something to communicate with your healthcare provider so that they can consider that as a more likely player on the differential diagnosis, right? Mm-hmm. So one thing that I hadn't mentioned is the reason why endometriosis is such a frustrating condition is because you can only diagnose it by seeing it. And so you can't see it on an imaging study. You can't see it on a lab. You can't see it on an ultrasound. And the presence of it doesn't necessarily go with the severity of the pain. So the way we clinically diagnose it is to do surgery, to do laparoscopic surgery, a diagnostic laparoscopy, where we put a camera into the person's abdominal cavity. So you have to undergo a surgery to simply be diagnosed with it. And with surgery comes the risk of surgery. Mm-hmm. And of the women that undergo a diagnostic laparoscopy for pelvic pain or dysmenorrhea, which is a medical term for painful periods, only 50% of those women actually get an endometriosis diagnosis. The other 50% are left with, we don't know why. We don't know why. Maybe your uterus is just contracting stronger because it's a muscle, and everyone's interpretation of pain is different. Maybe you're just more sensitive to pain. And so it can be a very frustrating thing for patients to deal with, because unless you want to undergo surgery, you may not ever have that confirmed diagnosis. And so sometimes we just empirically treat and see if the person gets better. Mm-hmm. Because the treatment, options are the same. And if they get better, then we say, okay, it's likely that you have endometriosis. Does that make sense?
Yes, that makes sense.
When we go in and we do a laparoscopy, what it looks like is if you were to take a cigarette and put it out on the uterus or the ovaries or the peritoneum, like it looks like a smoke burn. Yeah, that's what it looks like. Also, sometimes it can be more reddish in color. Sometimes it can be more white in color, which we say red lesions versus white lesions. But it literally looks like cigarette burns. But it also promotes scar tissue formation. So sometimes you'll go in and everything is just like stuck together, and the person's never had surgery before. You're like, oh, this person might have endometriosis because that blood is so abrasive that it can kind of act as a glue. So when someone's bleeding in their abdomen, it kind of makes things stick together. It can also collect as cysts in the ovaries, and we call those chocolate cysts because they're full of old blood. And like towards the end of your period, the blood starts to change color where it's more brown, more blackish color. As it has less oxygen content. And so those cysts can just be black chocolate filled. And then when those rupture, they are extremely painful because that blood is an irritant again. So as far as management, the management is suppressing your hormones because, as mentioned, it's a cycling of the hormones that causes that lining to bleed, right? So that can be very frustrating for women who especially want to have a baby because it's like, you're telling me I need to be on birth control to not experience these painful periods, but if I'm on birth control, how am I going to get pregnant? And so it's a frustrating medical condition to have, but that's truly the underlying method of treatment is suppressing your hormones, whether if that's through birth control or there's newer medications that kind of induce a medical menopause where they kind of turn off your hormones, and it's used to really kind of like basically keep the lining from cycling at all because you're not going through those hormonal fluctuations, and then that prevents them from having pain.
So Dr. Harris, oh, sorry, Dee, go ahead.
Would you say that new medication is more for people who are either past their childbearing ages or have no plans of having children? Or do you all still use that medication for people who want to have children one day, but their endometriosis is just like currently out of control?
Yeah, we can use it for both situations, but I have prescribed that for women that are of reproductive age because they just, they want 2-3 years apiece. Yeah. And also, endometriosis can impact your fertility because, like I said, how it can cause a lot of scar tissue where everything kind of coalesces like glue. It can block your fallopian tubes. And so then as you're attempting to get pregnant, you're experiencing difficulty where you're not getting pregnant because you got all this scar tissue from the endometriosis. And so that's also something to consider that I tell women, like, if you have an endometriosis diagnosis, it's best to be on birth control or something to hormonally suppress you until you are absolutely ready to try, because then you'll have a better chance of getting pregnant in a shorter period of time. And endometriosis typically gets better during pregnancy because you're not going through these hormonal cycles. And so a lot of women experience a lot of peace during pregnancy. They're like, I love being pregnant because you're not having a period. So you're not having to go through that monthly, bout of debilitating pain.
Which I can only imagine how extreme that is. I was going to circle back around to what you said about the diagnosis process being so difficult. And one thing we like to do is equip our listeners who might not be as knowledgeable or go into a physician's office and really not know what to say. Is there anything that people can say in terms of the conversation they can have about the symptoms that they are experiencing, or questions that ask that can kind of help through that process to get them to a point where they can actually decide if they want to go the surgery route or do the empirical treatment, just to kind of help that process move a little bit faster?
I would say I would have endometriosis as something on my radar if you are taking Tylenol and ibuprofen and you are getting no relief. I would definitely be concerned that you might have endometriosis and mention that to your healthcare provider. And as far as deciding if you should undergo surgery to have a diagnosis, I would say it never hurts to try the treatment first, because you have the risk of surgery, of bladder injury, bowel injury, bleeding, scar tissue formation subsequent from having a surgery. And so I think, what's the harm in trying the treatment first? And if you get better, and you know, hey, I don't have 100% diagnosis, but I think it's probably very likely that I have endometriosis because I am on the treatment for it and it is helping me.
To our listeners, like Dr. Harris said, you know, try the treatment. Like, she is a trained surgeon as well, and she's telling you it's okay to try treatment before going that radical route of getting a surgery. Sometimes it's probably necessary, but ask questions, and know that there are options. I feel like that's like the main point of talking this through with an actual practicing provider today, is just so you all know that there are options. And so then I guess we'll go ahead and move to our next GYN condition, which is polycystic ovarian syndrome. So according to the Centers for Disease Control and Prevention, PCOS, that's that polycystic ovarian syndrome, but I'm just going to call it PCOS, is one of the most common causes of female infertility, affecting 6 to 12%. So that's as many as 5 million women who are of reproductive age. It's common for women to find out that they have PCOS when they have trouble getting pregnant, but if it can also begin after their first menstrual period, so as young as age 11 or 12, but can also develop in the 20s or 30s. So, Dr. Harris, can you tell us a little bit more about what PCOS is and how that presents clinically?
Yes, so polycystic ovarian syndrome is the subsequent of a hormonal imbalance. So you have hyperandrogenism. So you have a higher than normal level of testosterone and estrogen. Okay. And so what that does is when you have a higher than normal level of testosterone, that suppresses ovulation. And so that is how that impacts your fertility. And so you become an egg hoarder, as I like to tell patients, where your eggs that you normally release every month, you're not releasing them. And so when you do an ultrasound on a woman with polycystic ovarian syndrome, her ovaries are usually very large and full of eggs, all these tiny little cysts. And on an ultrasound, it looks like a true egg, like a chicken egg, right? With this string of pearls. That's a buzzword for you, D, when you're taking your test. Okay. String of pearls around the periphery of the ovary. And that is, what we commonly see with polycystic ovarian syndrome. And another symptom that women will experience is because ovulation is the true on and off switch for your periods become very irregular, almost unpredictable, where sometimes you don't have one for months. And then when you have a period, it's the period from hell. It lasts weeks. It's super heavy because ovulation is that like switch from the prolific phase to the secretory phase. And then it gives an off switch for your period because as that egg is not fertilized, it sends out the signal, okay, we didn't get fertilized. Time to go back to the other phase. And so when you have that disconnect, your body is just all awry hormonally. And then when you have a higher than normal testosterone level, you can have acne, you can have a lot of facial hair. That's one of the things that women with polycystic ovarian syndrome are really bothered by, especially some male pattern type of facial hair, and then thinning of the hair on their head the way that men experience it as they age, where they have the balding, the temporal balding, and the balding on the top of their head. And so you have less hair in areas you want to have full hair and more hair in places you don't want to, have hair. And so it can be frustrating that you have to deal with these unpredictable periods, heavy periods, the abnormalities with their hair, and then also struggles with the infertility. So it is also a very frustrating condition. But this is different from fibroids and different from endometriosis, and that there are non-medical management options and it can be prevented. So one of the common things is I feel like a lot of people don't want to discuss their weight, okay? But our fat cells make estrogen. They make estrogen. So when you are overweight, you have a higher than normal estrogen level. And then when your body is so overwhelmed with all this estrogen, it's like, what am I going to do with all this estrogen? It starts converting it to testosterone. So for a lot of women or teenagers, you see, some bigger teenage girls, and they have very irregular periods, and they're experiencing these very heavy periods. So a lot of times our first step is to get the diagnosis by checking some hormone levels. Okay, checking the estrogen, checking the testosterone, doing an ultrasound is something else that we can do to diagnose PCOS. And then the first thing that I do is say, let's talk about your diet. And not necessarily just losing weight altogether, but recognizing that with that elevated estrogen and testosterone also comes an insulin resistance. So you are more prone to being diabetic. Mm-hmm. You're more prone to having hypertension from the estrogen and the testosterone. And so we really need to take an approach of reducing our carbohydrate intake to lose weight and to counteract the hyperinsulinism. Because your body is making more insulin, which makes you more resistant to breaking down carbohydrates. So it's like, a thin person, they can eat a cookie and, going about their business, but somebody with polycystic ovarian syndrome, it's like you immediately are going to just store all that carbohydrate, which then in turn creates a higher insulin level, which creates even more resistance, which creates even more estrogen because you're not breaking it down, you're storing it, which creates even more weight, which creates even more of the symptoms. And so it's like this vicious cycle. And so you can break the cycle by what you ingest in your body and being very carb conscious.
That's really good to know. I'll even give my own little personal experience with PCOS. So I was never formally diagnosed with polycystic ovarian syndrome. However, about 2 years ago, I started getting acne for the first time. Like I didn't have any acne when I went through puberty, but I'm like at this great age of 22, all of a sudden I'm getting acne on my face. And I would notice it would come near every menstrual cycle. And so at first I went to primary care I went to a dermatologist first, and then they gave me some meds, didn't work. And so then the dermatologist was like, like you're not overweight, but I think you should go to OB because you're telling me that it's lining up with like your periods. Went to OB, got that painful ultrasound, Lord have mercy, and found out, so they didn't diagnose me with PCOS. They said you have polycystic-like ovaries. So they said they saw a few. It wasn't enough to like formally diagnose me, but they're like, we can see some cysts. And I had already had a history of ovarian cysts that ruptured when I was like 19. And so they're like, first thing they told me to do, they was like, work out. And not because I'm overweight, but they were like, you should just go to the gym and see if that helps. And I can honestly say I did. I consistently went to the gym at least 4 times a week. And from that point on, I had the most regular periods that I've ever had in my life. Acne started going away. Like it was working. I'm like, wow, okay, lifestyle changes, working out. And then I got to the point where I got super busy and couldn't go to the gym as much. So I opted to get on birth control. And since I've gotten on birth control, have not had those issues at all. So that's just my own personal experience with like symptoms associated with those like polycystic ovaries. So definitely listen to Dr. Harris when she says like these lifestyle changes are just as important, if not more important than some of the pharmacological options. So with that being said, Dr. Harris, in the event that like, I don't know, because we do got to consider that some patients may not have access to a gym or may not have time to, go to a gym for whatever like financial barriers there may be, etc. So in situations like that, when going to the gym or losing weight isn't as easy as it is for, other people, what would be the next step? Like, is there any medical management? Like, how do you all go about treating someone like that?
Yes. So, I think a lot of times we use the barriers that we have as an excuse. And I would empower patients to say, the biggest thing is about your choices that you make, right? And it's simple things like when people tell me, oh, I don't have money for a gym. You know what I used to tell patients? Stand in front of the TV and jog in place. exercise is simply just moving your body. That's all it is. So
That's
however you
yeah.
need to move your body, if it's jogging in place, if it's walking back and forth in your house, if it's just doing jumping jacks or push-ups or sit-ups, like as long as you're moving your body, you're working out. You don't need any expensive equipment. You don't need a gym membership. As long as you are just moving more throughout your day, you will be able to impact your hormone levels, right? By just moving more. And then also just being conscious of your diet. You know, when you have an option, if you have a sandwich, you're like, ooh, maybe I shouldn't eat this bread. Eat the sandwich without the bread. Just roll up the cheese and the meat and just eat it that way. You know, we have choices. I feel like a bigger barrier is for those who live in food deserts where you know, you're relying on Family Dollar and a gas station or some mom and pop grocery stores and bodegas that don't have a lot of healthy options. They got a lot of chips and hot Cheetos and other sugary, starchy like bakery products, but don't have any like fresh produce. And I think in those situations, usually they have cartons of eggs, they have milk, you know, they have things where you just have to make different choices, right? But in regarding medical management, the solution again, like endometriosis is, and with your fibroids too, is just hormonal regulation, right? So you have this disconnect between your estrogen, your progesterone level, where typically you have more estrogen than you have progesterone. And so by taking birth control or getting an IUD that produces or emits progesterone, you can balance out that estrogen and progesterone to give yourself predictable periods, to decrease your hyperinsulinism. So a lot of times I will prescribe metformin, which helps your body become more sensitive to the insulin that you do make. And one of the side effects of metformin is that it can cause people to lose weight as well, which also is helpful for that situation. That method of losing weight is more so comes from your belly being upset. People don't talk about that. Diarrhea.
Yeah.
But you know, at the same time, it helps with the hyperinsulinism and it also helps with weight loss. But it doesn't necessarily help with the estrogen and progesterone mismatch. So typically, when you go into a provider and they want to put you on medical management, you'll talk about metformin or exercise or, you know, dietary changes in addition to birth control to regulate the estrogen and the progesterone until you get down to the point where you're more lean. Like you said, Dee, you know, you're not overweight. But for some people, that mismatch can come at just different levels of being overweight for them, right? And so just losing 5 or 10 pounds for some people is all that they need to impact their hormones and make the estrogen and progesterone match up. Just becoming a little bit more lean, decreasing those fat cells that are making that estrogen just a little bit, and they can create that pairing the way it needs to be. So I think that a lot of people just feel overwhelmed, like, oh, my doctor told me I need to lose weight. Well, for everyone, that's different. And I usually tell patients, let's just start off with a goal of 10 pounds. And then I would have them come back in. We would do monthly weigh-ins and we see how things are going. And then once they lost the weight, we would go off the birth control pills and see what their periods do. And because what works for me and what works for you might be different. And we don't want to take medications if we don't need them.
Absolutely. I love that. Thank you for sharing that with us. So yeah, to our listeners, just know that sometimes our lifestyle habits and choices are very, very important. It can have a direct impact on our health. So then I'm going to move on. So this is not a GYN condition, but it is a huge issue. Oh my goodness, huge issue. So talking about maternal and infant mortality rates, according to the Centers for Disease Control and Prevention, pregnancy-related deaths per 100,000 live births were 4 to 5 times higher for women of color than it was for white women. Additionally, as of 2020, it was recorded that about 880, somewhere around that, women died as a result of pregnancy or its complications. So I don't have any like specific questions. I just want to hear from you, Dr. Harris, more about this issue. One, like why it's an issue, and I don't know, advice, whatever you want to tell us about maternal and mortality rates. And I'm trying to keep it broad because I know that like we can go down so many different avenues, but I feel like you're more of an expert in this area. So I kind of just want to hear from you about this topic in general.
Yes. It's a tragedy. It's a tragedy. I don't know if any of you guys had the opportunity to watch Aftershock that's on Hulu.
Not yet, but now I'm interested in watching it.
Right. I'm like,
Yes. So the startup that I'm a part of, we had like broadcast to Facebook where we talked about it. But if you can watch it, you'll learn so much. And it follows the stories of several women. And it just puts a face to the statistics. You know, these women were just like all of us. They were accomplished, they were successful, they didn't come into pregnancy with medical conditions, but yet they all die. And it shows how their loss has impacted their families and their children and just our society in general. And I think the cause is multifactorial. I think firstly, it's because we don't have enough providers that deliver culturally competent care, truthfully. Like I said, when I first came back to Fort Wayne, I was the first Black African-American woman in my practice history that had been in existence for 55 years when I got there. Fort Wayne is the second largest city in Indiana. It shouldn't be that way. Like, that's ridiculous. And so to be taken care of by someone who looks like you, who understands your perspective, who sees you, who hears you, is so valuable. And there are so many studies out there that show that minorities, when cared for another minority provider, especially of the same ethnicity of them, their outcomes are so much better. And it's about that innate trust that we have when we're taken care of by someone. And with that innate trust comes a different level of communication. Where you feel comfortable sharing things with that person. For, you don't fear judgment or how you might be misinterpreted. And then also, you know that person will take you seriously and they're not going to blow off your concerns. And so there's just so much value to being taken care of by someone who looks like you. And that's something that I just want to drive home to your listeners, is that if you have the opportunity to see a provider that looks like you, please realize how valuable that is and seek that out, because it will definitely impact your outcome. And going back to the reason, why things are, there's a lot of implicit bias where Black women have been dismissed or not taken seriously. You look at people like Serena Williams, someone who's in peak physical form, right? Who obviously is knowledgeable about her body, right? She's an athlete who obviously is affluent and wealthy, that she can afford the best care. And there's no issues with healthcare access or lack of transportation or lack of healthy foods. When you consider the social determinants of health that affect our outcomes, none of those things contributed to her near-death experience. It was solely that her provider wasn't listening to her initially. And I think that's just, it's so valuable. You look at Dr. Shalon Irving. Have you guys heard of her? So Dr. Shalon Irving was a PhD who studied healthcare disparities, and especially had a focus and a passion for maternal mortality. Her research that she published through the CDC is the foundation for the Black Maternal Healthcare Caucus, from which the Momnibus and all this legislation has come from. And do you know she died in the postpartum period from pregnancy complications? Here she is, the leading expert, right, on all of this. And it wasn't because she wasn't knowledgeable. It wasn't because she didn't have access to great care. It's because she wasn't listened to. Mm-hmm. And I think that that's something that you cannot teach, right? Mm-hmm. You can't teach someone's ability to listen and be empathetic. And so that's why I feel like it's so important to be taken care of by someone who looks like you. Because even when you correct for all the social determinants of health and social economic barriers, still I, as a Black woman with an MD and an MBA, am 3 to 4 times more likely to die than a 15-year-old in rural America when I have a baby.
Yep. And that's something we preach, Dr. Harris. I'm so glad you're talking about it. It's just the need for us to advocate for ourselves. And if you don't feel like you're being listened to, you can always go to another doctor. Like, you really need to push your concerns out there, advocate for yourself until you find the optimum treatment needed, because it's ridiculous, these rates. And even that story you just said just kind of made me shiver a little bit that something like that can happen.
Yeah. It's terrible, but I think the good that is coming out of it is that now the common African-American woman knows the statistics, and they know that when they're pregnant, they're taking a risk. Like, something can happen to me. I can do everything right, and something can happen to me. And they're more knowledgeable about it, and they're bringing their moms with them to the prenatal appointment. They're having somebody else there when they have a baby. You know, they're having more support. They're utilizing more midwives. They're utilizing more doulas. And I think that that is an important thing, that, you know, we're getting the statistics and the healthcare disparity out there where more people are knowledgeable about it than had been in the past. And I think that is what will truly change outcomes, as people being more knowledgeable, more proactive, and saying to their providers, like, you know, I at Community right now, I'm the only Black OBGYN hospitalist, okay? And there's only one Black OBGYN generalist, and takes care of patients in the prenatal and the postpartum period. And this is the largest volume in the entire state of Indiana. There's one of her and there's one of me. And her name is also Dr. Harris. And she is an SROR as well. We have her on the podcast. So they call us Harris Square, right?
Oh, that's good. I love that.
Harris Square. They're like, here come the Dr. Harris's. And we take great care of patients. But we face so many obstacles because Dr. Harris's colleagues are frankly jealous of her volume. They say they don't understand why she's so busy. I don't understand. And it's like they don't even recognize that there's a difference when you are taken care of by someone who's culturally competent.
Right.
And there was this TikTok that was circulating that went viral. And I laughed when I saw it because I was like, I had this happen a few months ago. I should have made a TikTok about it. I'd probably be famous. But I had a patient who had a baby, and she kept patting her head, right? And the nurse put in a psych consult, told the social worker that she was concerned that the patient was exhibiting OCD behavior.
Oh, wow.
It was preventing her from breastfeeding because she kept stopping to pat her head. And she was concerned about her ability as a new mom to take care of her baby. And they put in a psychiatric consult to see if she needed to have therapy or medical treatment for OCD. And I called the nurse and I was like, this is not OCD behavior. When you're a Black woman and you don't have access to your scalp because you have a weave or braids or a wig, that is the way you scratch your scalp. Culturally, like, that's not something they teach you in medical school. And if you're not a Black woman, you would have no idea. You think this person crazy, right? And I'm just like, those are the things that can't be taught, and that's why we have the health. That was a perfect, just innocent display of how people can have the best intentions, but just because they don't have that cultural competency, the patient could have a totally different outcome and a totally different experience.
Yeah. Well,
I
I'm
saw
glad we.
that TikTok and I saw that TikTok and I also laughed initially because I'm like, oh, this is crazy. But I will say that I had the space to share that with my cohort, like my accelerated program cohort. I shared that TikTok and I let them know. So in the, because we have allies, that's very important to inform your allies. And I let them know. I said, hey, y'all, if y'all haven't already seen me doing it, because I wear braids like 90% of the year, but the day that you get a Black patient or a patient of color who is patting their head away, they are not crazy. They don't need a psych consult. Just ask them if their scalp is itching. 9 times out of 10, that's the case. If you see them pull out a rat tail comb, they are like, they're not trying to hurt themselves. They're just trying to get access to their scalp. And like you said, that's not something that's taught in medical school. I'm in medical school. They don't teach you that. But I'm the person that speaks up in class. We have an implicit bias training coming up when we start back, and best believe I will be given as many examples as possible for the sake of like their future patients, because it's just so important.
And that's the beauty of having people like UD and then Harris Squared, having you guys in Indianapolis. If you're in Indy and need quality care, Harris Squared is there, even though your lobe's probably crazy right now. But that's just beautiful to have someone out there, like you said earlier, making sure you have someone who understands you and looks like you. Another thing you said, Dr. Harris, is about being proactive with care, and that's something we're super passionate about as well, is preventative medicine, just giving people tools to get ahead. So is there anything from your perspective, whether it's screening or any other type of preventative care, that you will recommend women ensure are part of their regular maintenance routine?
Yeah, so we're just talking about just in general.
Yeah, in general.
So I would say, first of all, is to be knowledgeable about yourself and your medical history. I've mentioned that several times. Knowing what you're at risk for or at increased risk for. I know that my family dies from different blood dyscrasias or cancers. Can I prevent that? No. But can I be knowledgeable about that so that if I experience a symptom, I can go to get some blood work drawn to diagnose it and treat it earlier. So it's so valuable to talk to your family. I feel like in the Black community, it's kind of a taboo thing where it's like, that's our family business. We don't talk about it. I had my grandmother, when my aunt passed away from lung cancer, and I said to my grandma, I was like, I didn't even know Auntie had lung cancer. She was like, baby, somebody asked you, your aunt died of pneumonia. I'm like, what?
So common.
And I'm just like, what do you mean? She was like, we don't claim that. And I'm just like, there's nothing shameful about having a medical condition. And I feel like that's just something that's kind of innate in our culture, that we don't really talk about our medical problems, and it's something that's there's a shameful association to that. So I would say, first of all, just be knowledgeable and talk to your family and your elders about what's common in your family, to start that and to change that narrative. Secondly, being mindful about what you eat, how much you're exercising. If you're not hungry, don't eat. That's just like such a simple concept. But I have to remind myself that when I'm stressful and when I'm stressed at work and I see cookies, I was like, you want those feel good endorphins from, oh, this cookie is so good. That lasts like a couple of seconds. And so I always tell people, this helps me think about how many calories something contains, how long it would take you to burn it off, and you're probably going to put it back if you're not truly hungry. And then also just be knowledgeable about what the screening guidelines are. So, Pap smear, you start that at age 21. That is detecting HPV, which can cause cervical cancer. And you want to do that, based off of kind of what your personal risk is, at a frequency that you and your provider discuss. But once you become 30, they can specifically test you for HPV. And if you don't have HPV, usually you are in more long-term or more monogamous relationships in your 30s, and so you can space out the frequency of that screening. Mammogram screening for breast cancer is something that we start at 40. However, the American Cancer Society recommends 50, but I don't follow those guidelines. I follow the guidelines of the American College of Obstetrics and Gynecology, which is 40, and you do that annually. Colon cancer screening used to be 50. Then they changed it for African Americans to 45, and now for everyone it's 45 now. But I think it's important to recognize that as Black people, we typically get more aggressive forms of colon cancer and are diagnosed at an earlier age. Like, look at Chadwick Boseman for a prime example. And so no one really enjoys getting a colonoscopy, right? But you definitely not going to enjoy colon cancer treatment either. So I think is that you want the screening to prevent that, because colon cancer can be removed as a polyp before it becomes cancer, when it's just a hyperplastic or a precancerous polyp. And so it's important to recognize that by getting a colonoscopy, not only are you diagnosing, you're preventing colon cancer occurrence, right? And then also, I think it's so important to be vaccinated, which is a whole nother topic that is taboo in the Black community.
Yeah, a whole episode, yes.
Yeah, that's a whole nother episode about vaccination, right? But I use the HPV vaccine as a prime example. You know, cervical cancer rates are so low now in comparison to what they've been because we have the vaccine. And I think another thing that I want to drive home is a lot of people aren't vaccinating their girls because they feel like, I'm not vaccinating my daughter for an STD. Like, again, they're like, there's this taboo. And it's like, well, if you could prevent your child from having cancer with a vaccine, like, why wouldn't you get it? It's just the sexual association of it being, you know, related to HPV. And another thing is that a lot of times women will take their daughters to get vaccinated for HPV, but not their sons. And now the rates of head and neck cancer are higher than cervical cancer. And one of my best friends from medical school, she's a radiation oncologist, and that's the primary way you treat head and neck cancer. She said, every day I have to have this uncomfortable conversation with a man because the rates of head and neck cancer are increasing. How did I get this, doc? And it's from oral sex. It is from HPV. And so men are completely oblivious to that. They're not getting paps of their throat and oral pharynx, but they should. We really should do it. And, you know, now, like, let's just call a spade a spade. Everybody has oral sex. Like, it's just, you know what I mean? And people will have oral sex a lot of times more commonly than they have sexual, like, intercourse, like, as far as, like, penetrative intercourse. And so I think it's just something where people need to take away the controversy and the judgment. And it's, if you can prevent experiencing cancer from a vaccination, it's definitely worthwhile. And lastly, the HPV vaccination used to be, until 3 years ago, you couldn't get it after 27, and now it's 52. And I say that because most people don't know that. I myself got the HPV vaccine last year. I did my course during the pandemic, right? And I'm 39. And so it wasn't that it didn't work. It was that when they were going through the regulatory process with the FDA, they only had a patient population of the younger ages that met the requirement from the FDA to approve it to that age group, right? But we now know that, you know, there's nothing about when you turn to 28 that all of a sudden the vaccine's not going to work for you, right? They just needed to have a larger sample size, have the data that prove those outcomes, and that's why they've recently increased the age to 52. And then the theory at 52 is not like it's not going to work at 53. It's just that by the age of 52, most people are not engaging in sexual interactions with new partners, right? To have risk for HPV. So they just picked that arbitrary 52.
Okay, so continuing on educating our listeners, we want to ask, are there any healthcare policies regarding OBGYN that you would encourage women to be more aware of?
Yes, I would say this whole Roe versus Wade reversal, oh my God, that's at the forefront right now.
Mm-hmm.
And it's so important now to take a proactive approach to contraception. And because Black women are disproportionately affected by negative outcomes, we're going to be even more disproportionately affected, right? When we don't have the choice to terminate a pregnancy if we don't want to. And whether that's to terminate a pregnancy because you have a cardiac condition or a kidney condition where, you know, it's life-threatening for you to be pregnant, and you tried contraception, you had a contraception failure, I feel like we just have to be more careful and more mindful and consider contraception even if you hadn't before, because you really don't want to have an unplanned pregnancy right now. I think that's the leading thing when it comes to healthcare policy, because right now that's state dependent. Like in Indiana, we just had a special session last week. So all of that is changing right now. And so I think it's important to know if you needed to get an abortion today, could you get one? Like in Ohio, it's like a pretty much like statewide ban on abortion.
I'm in Ohio, I know.
Yeah. In Wisconsin, it's like a statewide ban. And so we're having people driving from different states to come to Indiana. But then now, as a result of last week, those patients aren't going to be able to get terminations here. But it's like, well, when is that going to come into effect? But they voted to pretty much outlaw all elective terminations. So that I think is probably of highest importance right now, is to be knowledgeable about what the policies are in your state. Because if you in Ohio, you need to be extra careful, because it's like you're pretty much stuck. You know, there was a 10-year-old girl that was raped that came to Indianapolis to have her termination because she could not get it done anywhere in Ohio. Yeah.
It's crazy.
That's so tragic.
Yeah.
Okay, well, you've given us so much great advice, but we wanted to ask if there was one piece of advice you could give all women about their health.
Oh, see. There's just so much. My goodness.
Yeah, you dropped so much, so many gems already.
Like, that's a hard one.
That's
a lot.
I would say the one thing that if anybody leaves here, like my driving home point is to find a healthcare provider that looks like you. Like if you could take away anything from the things that I say today, I think that's the most important, is to find somebody that looks like you, someone that understands your perspective, and know that if you don't find that, you can keep looking. You can keep looking. You don't have to just go to the person that your insurance assigned you to see. You know, you have choices. Another thing is that there are options. Sometimes there's dietary, non-medical therapies that you can take to change your healthcare outcomes. And I think so many times people think that if they have a medical condition, they have to be on medicine, and they have to be on medicine for the rest of their life, and there's nothing else that they can do. And for most situations, that's not the case. You have power in changing your healthcare outcomes from the choices that you make and what you do and how you live your life. And like you ladies mentioned, I'd rather take a proactive approach than a reactive approach.
Amen. Dr. Harris, I will just say we are so grateful for you, and just I'm sure your patients are grateful for you too. We are so proud to say you are a soror, your passion, your excellence. It's just top tier, and I just want to say thank you for every single thing you do, even right now, helping us educate our communities with all of the advice that you have given will impact so much. So just thank you. But I know your road hasn't always been just swiftly easy. You probably have challenges every day. So one of our last question is, just through everything that you have accomplished and been through, how do you keep it pretty in practice?
Ooh. Wow. I would say, so like I mentioned before, like a major turning point in my life was losing my dad. And so when my dad, we decided to become do not resuscitate DNR, and he was coming to terms with it. For a long time, my dad didn't come to terms with his disease process because he was such a strong faith. And he would always say, I know what the doctor says, but God is the ultimate healer. He has the last say. He can heal me. Even when they say there's nothing else they can do for me, his faith and his spirit just wouldn't let him give up. And me as his daughter, I felt like I was in an awkward situation where I know what the textbook says. I know what the disease process is, but he's my dad. And I'm not going to crush his spirit, and I'm going to be there for him. And if he wants to believe that God is going to heal him, that's what's going to happen. You know what I mean? But I was still trying to be an advocate for him and to fight for him. And that entire experience was so eye-opening for me because I witnessed healthcare disparities firsthand, because I would see how they treated my dad, and I would step forward and be like, hey, that's my dad, Dr. Harris. And I would see how things would change.
It changes real quick. Yes.
And when I'm like, what's his labs today? Oh, you haven't even looked at them? I know there's critical labs there. Mm-hmm. Like, it would help hold people accountable. So I learned so much about healthcare and healthcare disparities from going through a very unfortunate circumstance of losing my dad. But I say all this to say that one of the last things my dad said to me was, it's great that you're successful. It's amazing, but you can't take this with you. And at the end of the day, your patients aren't going to be at your bedside when you transition. Your family is. And so you got to keep your priorities in perspective. And you have to spend more time outside of this hospital than you spend in it. And when he said that to me, I was just like, my priorities are screwed up, because I put so much emphasis on accomplishing my lifelong dream from a career standpoint of, I'm changing these patients' lives. I'm decreasing infant mortality. I'm decreasing maternal mortality. But at the end of the day, I'm still just Elicia, right? And so it was so important that I lived for myself. And there's so many things that are more important than accomplishments and money and degrees. And like, you only have one life to live. And so when I decided to make the transition to become a hospitalist, I found a sense of balance where when I am at work, I am giving my all. I am changing outcomes for patients. I am delivering culturally competent care. Outside of work, I have time to advocate and be passionate and, pursue my dreams and my interests. And through my startup, impact healthcare policy and the way we do prenatal care. And all that I say is that finding a balance for you is so important. Taking your mental health seriously is so important. Prioritizing yourself is so important, because you cannot pour from an empty cup. And that's what a lot of healthcare professionals are doing every day. They're just going through the motions. They're not happy. They don't feel fulfilled. And then later in life, it's like, well, I have bettered all these people's lives, but I've ruined mine. And so I think it's so important as physicians, we're so altruistic where we want the best for everyone. But at the end of the day, your happiness is also equally as important.
It's a whole word. You just, yes.
I'm like, I'm listening to that for myself.
Yes.
Like, I know listeners are listening, but I'm a listener right now because wow.
Facts.
No,
These are facts.
Yes, that's our whole word. Thank you for blessing us with that. Thank you for blessing us with knowledge, with advice, with guidance. I know our listeners are going to get so much out of this. We didn't even get through all of the questions that we had. So we would love to have you come back for another episode and just continue to help us educate the community because it's so needed. And like I said, our listeners got so much, women got so much out of this, healthcare professionals, if you're listening, hope you got so much out of this as well. And like Dr. Harris said, prioritize yourself through everything. And no matter what you do, make sure you keep it pretty in practice. Thank you.
As always, thank you for joining us for the ride. Be sure to keep in touch by following us on Instagram and subscribing to our YouTube channel at Pretty in Practice. Feel free to send us a DM of any topics you want us to discuss, and you might hear them on a future Pretty in Practice episode. Keep it pretty.